we are going to start. Well, thank you very much, everyone, for coming to our bi-weekly Innovative Discovery Seminar. We are honored today and really delighted to have Dr. Metlay from Harvard coming to talk about improving outcomes for patients with pneumonia. So before I start introducing Dr. Metlay, I have some housekeeping items to go over. Please make sure that you sign in. Please RSVP so that we can better prepare for the next session. Online participants, please keep mics muted unless asking a question, and please keep video turned off. Use the chat feature in BlueJeans if you have any technical issues. Our next conference will be about differential privacy techniques. It's related to our big data grants and use of data. It's on November 20th, so it's next week, and no, a couple of weeks. And then we will have Applying Network Theory to Medicine on December 4th to finish out the calendar year. All the previous presentations are available on our website, CTR, Delaware CTR, DE-CTR.org. Maybe I'll wait a few seconds until everybody gets in.
I'm fine. Yep, all good with me.
So we are really delighted to have Dr. Metlay here with us. Dr. Metlay is currently Professor of Medicine at Harvard Medical School, as well as Chief of the Division of General Internal Medicine at Massachusetts General Hospital. Prior to joining Harvard in 2013, Dr. Metlay was at University of Pennsylvania, where he became professor in medicine, emergency medicine, and biostatistics and epidemiology. He obtained a PhD in immunology from Rockefeller University, his MD from Yale, and a Master of Science in Health Policy and Management for Harvard. While at University of Pennsylvania, Dr. Metlay led the Doris Duke Clinical Research Fellowship from 2006 to 2010, and was also the co-director of the Robert Wood Johnson Foundation Clinical Scholars Program. In addition, he was the director of the Center for Healthcare Improvement and Patient Safety from 2009 to 2013. He's very well known nationally and internationally, has had multiple awards over the years for excellence in teaching and in research. Last award in 2014 for excellence in research from the Society of Hospital Medicine. He has been the chair of the NIH Review Section for Infectious Disease, Reproductive Health, Asthma, and Pulmonary Disorders since 2013, has had multiple federal grants related to educational programs, or more specifically to research into community-acquired pneumonia, and has a very long list of peer-reviewed publications. So we are delighted to have you here, and thank you everyone for coming. There are still some seats available here.
Well, thank you very much. Ooh, this is too loud? It's okay. It's okay. I've never been wired like this. I'm very nervous about this. So a disclosure and a personal note. I actually was here not so many years ago, I guess before the Value Institute, but I thought maybe for the Center Outcomes Research, Edmondo Robinson had invited me, who was one of my former students, and I spent that time talking about research in the quality improvement space, and particularly using the model of antibiotic improvement, how to reduce overuse of antibiotics. And some of you may have seen a lecture title earlier for this lecture on that very topic. So if you came for that, I'll answer any questions you want about overuse of antibiotics. It's bad. That would be the punchline. It's hard to change. But because the proximity, I didn't want to talk about the same thing. In fact, I wouldn't, in general, I think people get tired of me pretty quickly, so I wasn't sure I should come back so soon. But I had been invited actually by Seema Sonad, who is a dear friend and colleague, who many of you I'm sure know. And so unfortunately, and the irony of these things, in the time between when she sent me the invitation and I mulled it over and decided whether I should wait, unfortunate things transpired. So in many ways for me, this is a kind of a debt and an honor to be paid. And I certainly do think that one of the themes that I'll talk about in the lecture today is the way that, when you have a lot of evidence around something and it can be confusing, sometimes you really need to kind of take a step back and try to understand what the big picture is. And I do think that amongst her many talents, most importantly being just an amazing human being, one of the things about Seema as an investigator and a colleague who I got to work with for many years at Penn was her ability to distill very complex things into simple ideas. And it was through that, I think, that many people learned from her. So I really thank you for this opportunity. It means a lot to me. Okay, so the context of this a little bit, I'm talking about pneumonia, has a kind of a clinical bent to it. I know there are a mixture of clinicians and non-clinicians in the room, but I will try to look at it from the lens of a researcher as well. This is where I conduct most of my research, to give you some insight into what I think are the interesting research questions and how we could continue to study them. I certainly don't mind being interrupted during the talk. I promise to leave 10 to 15 minutes at the end. I'm a very, very good clock manager. That's how you get to become a chair of an NIH study section. That's the only qualification that you have to have, is you need to be able to cut people off. And I've really mastered that skill in my life. Okay, so what we're going to do is, the way I'm going to structure the talk is to lead you through, and this is very much on my mind lately because I'm one of the chairs now of the IDS-AATS pneumonia guidelines for adults, which comes out supposedly every 5 years, but it's been almost 8 years because there's been so much politics around this and difficulty in getting a group together, but we are getting pretty far along. And so this stuff is very much on my mind, is what is the state of evidence and what should we be doing for patients, particularly admitted with community-acquired pneumonia? And what I'm going to talk about here are really what I think are three major areas of work in which there's really some evidence of what we should do, but still also a lot of uncertainty. And so I'm going to divide them into diagnostic issues. Typically, a person doesn't walk through the door and tell you what they have. They come with symptoms, and we have to figure out how to go from symptoms to diagnoses to treatment. And there's a lot of movement in that space, and I think also a lot of opportunity for really interesting research on what we should be introducing at point of care. The use of rapid diagnostics in particular, I think, is a huge opportunity to think about how that impacts outcomes and cost of care. Then we'll talk about treatment. Obviously, it's an infectious disease, and so we have to talk about antimicrobial use and what we know and what we don't know. And I'll talk a little bit about that and why it's become a somewhat dynamic or moving target, in particular because of this emergence of resistance. And so some of the therapies that we've used for years are less clear that we can continue to use them. And then lastly, I'll talk about prevention, because this is really one of the most interesting aspects of pneumonia and infectious disease in general, which is how we can actually do things at a public health level that can dramatically impact the disease. And the last 10 years in this space have been, I would say, really extremely dramatic. This is a figure that came out of a paper from a colleague of mine who trained in Boston as well, Greg Runke, who used, actually these are CMS Medicare claims data to look at the 30-day mortality associated with diagnoses of community-acquired pneumonia. Actually, the theme of the paper, which I find sort of striking, is that things are getting better. But I would say to you, if you looked at this graph and you looked all the way back to 87, and by the way, we could extend this line probably to about 1950 or probably 1944. We'll talk about that when penicillin was introduced. The survival curves for patients, particularly in the inpatient setting with pneumonia, have moved almost not at all. I mean, it is true that over this time, the average mortality has dropped from 13 or 14% to perhaps around 10%, but I hardly feel like that's like a huge victory here. And although people can probably point to some things we've done in the hospital around ICU care and infection control, the fact of the matter remains is that this is a major still problem from a mortality and a morbidity point of view. And I think we often forget about that because, I mean, here's the grass is always greener whining part of me. Like, most of when we think about the burden of illness in this country and we think about where the NIH spends its money and all, we think about chronic diseases and cancer and cardiovascular disease and, obesity, dementia. But all of those things actually do converge eventually on endpoints that are often very commonly associated with infections and particularly pneumonia. Just a point also that, most of my work has been domestic, but if you look internationally at the burden of illness associated with respiratory infections and particular pneumonia, it's a huge problem. So here I'm showing you infant mortality due to Streptococcus pneumoniae, which we'll get to in a second, is the bacteria responsible, the largest share of any bacteria responsible for pneumonia. And this is excluding children with HIV. So even if you said, well, there's a lot of immunocompromised patients out there, that's true. But if you look in sub-Saharan Africa and other places, the death rates to respiratory infections, so pneumonia and influenza combined, continue to be the leading cause of death in the developing world. That's a sort of a striking thing. I don't think we would necessarily have thought that if you think about what people are dying of. But this is a sign of what's going on in terms of public health infrastructure, ability to get prevention strategies out there, a whole host of those sorts of issues. I do want to introduce a little microbiology here. This is not a microbiology talk, and I'm not going to promise you do too much of this. But one of the things that we talk about, the treatment of pneumonia and the management of patients with pneumonia, it's easy to start to forget that there's a third party in all of this. It's not just the doctor or the health system and the patient. There's actually an organism that's being involved here. And the role of this organism is going to turn out to be very important in thinking about some of the prevention strategies. So this is a gram stain of sputum from somebody with pneumonia. We almost never get this anymore unless you really want to be cruel to the medical students and make them do it, because it turns out in study after study, despite the fact that we can actually get really interesting diagnostic information, people never actually pay attention to it. It's a separately interesting issue about physician behavior. And these are gram-positive diplococci, which are the classic streptococcus pneumonia that cause pneumonia. It's ubiquitous. We're going to get back to this. This is very important in terms of prevention. It's carried all the time in human hosts. It doesn't live in any other reservoirs, and it's transmitted continuously. I dare say there's plenty of it in the room right now. You should stay, but still. When we started this work, we focused primarily on adults, but I will talk a little bit about children in a second. And one of the things which is well known about pneumonia and pneumococcal infections is that there's a steep rise in incidence as people age. And this has given rise to the old saying that pneumonia is the old man's friend. Osler, who's sort of one of the first to really write a lot about pneumonia, famously actually died of pneumonia. He actually had the house staff tap his empyema, which seems a little creepy to me. I've just done rounds in the hospital in Boston. I'm pretty sure I'm not letting the house staff going anywhere near me with a trocar. But it remains a major issue as adults age. There are important disparities, and we're going to get back to this. In this country, African Americans are probably 1.5 to 2-fold more likely to develop pneumonia and die from pneumonia than whites in this country. Native Americans have even higher risk incidence of the disease and mortality. And to where I want to go with this, and we really don't understand why from a policy point of view. And this is a really important issue that we'll come back to. Analogously, these are not two separate points, but there is a steep income gradient for this illness. I realize this is at the most destitute levels here, but that exists in this country. And as you look across income gradients or neighborhoods by income gradients, the risk of contracting pneumonia and dying from pneumonia goes up quite dramatically. So it's out there in high rates. All right, so I said I was going to kind of break this into 3 components and talk about what I think are sort of the interesting clinical issues and shed some light on where the research is. So this is an important problem in diagnostics, I think, in healthcare, which is that often we're sometimes trying to find a needle in a haystack. And I think we sometimes don't fully appreciate the limitations of diagnostic testing in those kinds of settings. So if you look in series after series after series of patients who show up in a physician's office or in a hospital emergency department or in an urgent care clinic or in a CVS minute clinic complaining of a cough, which is sort of the sentinel symptom of somebody with pneumonia, usually somewhere around 1 to 5% of those patients will have pneumonia. Right? So said otherwise, 95% of patients who go seek health care when they're coughing, acutely coughing, say less than 4 weeks of coughing, don't have pneumonia. And I would submit to you, although there's a lot of back and forth about this, the vast majority of what they do have, which are usually viral respiratory infections and bronchitis, which is largely a viral illness, don't need to be treated like pneumonia. And said otherwise, which is really the other talk I gave last time I was here, we treat 100% of these people typically as if they have pneumonia by giving them all antibiotics, when in fact 5% of these people need antibiotics. But the challenge is, what kind of a test can I put in the hands of a provider that's going to allow them to go from a 5% probability to 100% probability, right? And avoid, too many false negatives in a way that's going to allow you to undertreat the patients who really need it. So for most doctors, their concerns are going to be, I'd rather overtreat 95% of the people and rather than risk missing treating 5% of the people of what I think is a life-saving therapy. And this kind of thinking, which I think underlies a lot of physician decision-making, is really an important issue to try to grapple with, which is, how willing are people to trade off risks and benefits when they make these kinds of decisions? This is just to illustrate this point. It's a different talk, but like if you remember anything about me, you should remember I've spent like my entire life trying to convince people of this graph, which is that when patients come in coughing, if they don't have pneumonia, which as I just said is almost certainly true anyway, they have no benefit from being treated with an antibiotic. None. This is trial after trial after trial. This is doxycycline. Pick your antibiotic. There's no evidence out there whatsoever. Days of coughing, delayed admission to hospital, doesn't matter. And yet, there's a HEDIS measure associated with this. We rarely think about it very much. It's a quality measure, and most health systems probably get a scorecard of around 80 to 90% of the time they're giving antibiotics for this condition, even though the target is like 10%. Okay, so actually they reverted the measure so it would look more like other measures. It's now the percentage of time you've avoided giving antibiotics for somebody with acute bronchitis. And most people score around 10 to 20%. And so it's public out there, but nobody knows what to do about this because this problem is so embedded. And I would submit that the problem is that most people are worried about that 5% and they don't know what to do with it. All right, so that's the issue here, which is that there are some people probably who still think that antibiotics have some benefit here, but the majority of, if you do lots of surveys, and we've done lots of focus groups and surveys with doctors over and over again, the majority of the time the issue here is that they really don't feel like we've given them good enough tools to make this kind of precise diagnosis in acute care. And they're unwilling to take a small risk of being wrong, withholding therapy, weighed against the large risk of overtreating. And it turns out that if you study, there's a lot of people have done this over the years where they've actually studied things like history and physical examination as if they were diagnostic tests. And you ask traditional questions around what's the sensitivity and specificity of listening to somebody's lungs or taking their vital signs or measuring fever. The point of this graph is to say that the sensitivity and specificity of most observable characteristics of patients, what you can get out of a simple history and physical, is not that good. And so even though I wish doctors would do a better job at sorting out those patients who have pneumonia from those patients who don't, the truth is that most of what we train people in and how to listen to the lungs and take a history does not separate those populations very well. And so if you had all of the classic findings of pneumonia, cough, fever, tachycardia, pulmonary findings on exam, in the largest series, the best studies, at best, maybe 50% of the time those patients have pneumonia. So you can take a patient in front of you, you'd say you can make it about a 50-50 guess that they have pneumonia, but you'd still be 50% of the time wrong. Right? Which is why, when we put these guidelines out years ago, we sort of recommended and in some sense insisted, and it was very poorly received, that you should never make the diagnosis of pneumonia without getting a chest x-ray, because only a chest x-ray, and even a chest x-ray is imperfect, but only a chest x-ray can confirm the diagnosis. Many provider groups are very unhappy with this issue, right? You're in a practice somewhere. You're going to send somebody to the emergency department or to some radiology suite somewhere. They're standing right there. You can give them a Z-Pak in 30 seconds. Why would you do this if you're going to treat them anyway? So the reception to this has been very difficult. Now, on the other side of the coin, it does turn out that if somebody really looks very healthy and is otherwise normal, you can get close to ruling out pneumonia. But the empirical question to think about from a research point of view is, how low does the risk have to be for someone to be willing to not give a life-saving therapy? Right? Is 1% risk of the patient having pneumonia not treating them low enough? Does it have to be 0.1%? That's the question. Turns out for most doctors that number is extremely low and probably not achievable, which is part of the problem. We've created algorithms, I'm not going to spend a lot of time on this, which help doctors think about whether they're in a low, intermediate, or high probability category of whether a patient has pneumonia, and now have run a series of trials of this kind of intervention where we're trying to give doctors more decision information or more decision support at the point of care. You'll already see we did this trial with Geisinger. It gave me a very nice introduction to the Pine Barn Inn in Danville, Pennsylvania, for those who've spent any time there. Last call is at 9:30. That's really important to know. And so we actually had funding to do a cluster randomized trial of about 30 primary care practices where we asked, well, if we gave doctors better information about how to sort out the patients who should get antibiotics from those who don't, or those who have pneumonia and those who don't, will they actually do a better job? And I'm showing this in part because what happened was that the control practices, what we're doing here is we're looking at doctors' accuracy of using antibiotics and prescribing antibiotics for all comers who come in with an acute respiratory illness as a marker of how good they're doing, right? We already think they're over-treating, What we're hoping is that doctors will reduce their prescribing and be more accurate. And at the control sites, doctors didn't move at all. But at the intervention practices, so these are thousands and thousands of visits over a couple of years, whether we gave them that decision support in literally a poster that went on the room in the exam room or a laminated card that went in their pocket, or we built it into their electronic system, which is Epic. What's it here? Is it Epic? So we're about to do a $1.5 billion conversion at Partners Health System into Epic, and the go live date is in 3 months. Let me just tell you, I see some nervous people. And so it turns out that although it looks like this is a little bit better, statistically these are the same. So this is important because I think right now on electronic platforms, there's some assumption that if you have something smart to tell providers, just build it into the electronic system. That has to be better, right? Put it at the point of care. So this is like, you put in the symptom, it gives you a templated note, that it connects to smart order sets, it makes it really hard to order antibiotics. It works, and if you do it for another year, it works even better, but so does just telling doctors what to do. And actually, the ironic thing is that you can look in the background of these systems, and you can see that doctors never actually use the decision support. And so this is an argument in favor of really trying, and I'm sure you guys are at the front edge of this, thinking about how, as we continue to tweak and implement new ideas onto the electronic platform, to actually try to study them in a controlled fashion. Because the downstream problem here, so Geisinger didn't need to put this into Epic. They could get just as much improvement on their HEDIS scores, which they did, by just putting these posters in the room. You say, why not just put it into Epic? Because there's 50,000 things in Epic. It's a doctor overload problem. And the doctors hated it, even though it worked, because they also were trying to manage hypertension and diabetes in the same visit, and this thing was getting really in the way. And so I think, as I think about this, and I know this is going to be a problem in my own institution, we have very low barriers to turning on a bright idea. We have enormous barriers to turning off a bright idea, right? Like we won't kill stuff. So I would say, like, if you want to claim that you have an innovation center at your health system, I would like to know you also have a de-innovation center, because 98% of the things that seem innovative in this room turn out to be not so hot when you put them into play. And we rarely know that because we don't study it. I think this was very illustrative for us in that regard. Now, what's coming down the pike is something called procalcitonin, which is a point-of-care test, which is a long story of many other previous tests, SED rates, white blood cell counts, which was the idea that all this history and physical stuff isn't as good as it can be. We need to use rapid diagnostic tests. Actually, it's an infectious disease. You think if you could do a rapid viral panel and something else, maybe we could even do it better. I'm not going to review all the work in this area, but I think there's a lot of really interesting opportunity to start to study point-of-care testing in this kind of domain. The European experience has been very favorable. I think not as much in this country, but I think it's going to change things such that you could really actually sort out those patients with pneumonia from those who don't, just based on a rapid diagnostic test at the point of care. In this country, procalcitonin is not a point-of-care rapid test. It is in the EU, but it will be soon enough, and it will change how we think about diagnosis. Okay, I'm going to move on, make sure I leave time. So recommendations. I already mentioned that it's been now almost 9 years since the IDSA-ATS released recommendations of how to treat patients with pneumonia. It turns out that in the interval, the American Thoracic Society developed very, very strong guidelines around conflict of interest and participation in guideline development. You say, well, how did a general internist start chairing the Infectious Disease Society, American Thoracic Society guidelines for pneumonia? It's like, I'm the only person apparently who doesn't have conflicts, because they went through a lot of people before they got to me, I can tell you. So it turned out they said to me, what drug companies have you like? I said, they don't even talk to me. So it's been actually very hard to put together a committee for this purpose, but we now have one, and we've been kind of marching through these guidelines to try to figure out what we're going to do. So those who remember, the guidelines fall into whether you have hospitalized patients or not. And interestingly, in the outpatient setting, probably the most controversial thing about the last round of guidelines, and this will come up again in the next round, was that the statement here that there were these sort of preferred therapies, which are macrolides and tetracyclines, fluoroquinolones, which are out there, respiratory fluoroquinolones, which have become heavily utilized, were seen as an alternative and not supposed to be first line, unless you were concerned that you had too much resistance in your community. So in adults, particularly around the bacteria that cause pneumonia, particularly around pneumococcus, there's a lot of emerging resistance to macrolides and tetracyclines and beta-lactams. But there's no resistance to fluoroquinolones. All right? I'm not going to tell you why just yet, but I'm going to reveal it at the end. It's like the surprise part of the story. And so if you're a provider, this is kind of like a sure thing that you're never going to have to combat resistance if you use this. Urinary tract infections, other things, yes. But for respiratory infections, you will never have a problem for the common pathogens if you use this. And yet, we don't want people to use it because if you overuse it, maybe it won't be around later. Um, but here's the problem. They said, but we understand that if you're concerned that the first-line therapy might fail, you should probably go to it anyway. And it turns out that in many regions, we're already at 25% macrolide resistance. So in many ways, the guideline was telling people to use things like levofloxacin as first-line therapy, which is not what they wanted to say, but that's how they said it. And so it's an interesting issue when you think about guidelines. You're trying to get people to do things that are locally smart. You're writing national guidelines, but you sort of are limited because you don't want everybody to write their own little local guidelines. And this was a failing, I would say, of the past version. So this is going to launch me into just a few minutes talking about bacterial resistance, which is tied to the prior talk I gave a couple years ago when I was here, which is the overuse of antibiotics. So for many years now, the CDC and other sentinel groups have been tracking the percentage of clinical isolates that are resistant to traditional antibiotics for a whole variety of infections. This is for pneumonia, in particular for pneumococcal isolates, and this is penicillin resistance. So through around 2000, the program was defunded during the Reagan years. It's interesting. And then in 2000, you can see this sort of steep rise in the percentage of clinical isolates that were resistant to penicillin or amoxicillin. And this was creating great consternation amongst people because this is a very famous graph from a paper that was published by Bob Austrian. So this is my Bob Austrian quick sidebar. So Bob Austrian, who's known as the father of the pneumococcal vaccine, not the Prevnar that we give now, I'll talk about that, but Pneumovax, the 23 polysaccharide vaccine that we've been giving for decades to older adults. He was working in the 1940s on developing a pneumonia vaccine. And then, I don't remember which company it was, pulled his funding from doing a trial of the vaccine because in 1943, 1944, penicillin. And everybody decided there was no need for a vaccine anymore for pneumonia because we could just treat it. So why would you prevent pneumonia? And Bob Austrian passed away a few years ago at the age of like 93. He came to work up until the last day when he died. Spent 70 years of his life studying just this one bacteria. I once actually asked him, I thought it'd be like this profound moment in my life, like, why would you choose to do that? You know, spend your 70 years and study only one problem as a researcher. And I was looking for some profound answer, and he said, why not? There you go. Why not? So he was unwilling to give up on the idea of a vaccine. So he did a very famous paper that was in the Annals, it was Austrian in Gold, that came out in the early 60s, where he showed the survival curves for patients with pneumonia. Before the introduction of any therapy, the introduction of serum therapy, immunoglobulin really, horse serum, wasn't very well tolerated, and then the introduction of penicillin. And what he pointed out was, undoubtedly, penicillin has saved many lives. But in fact, the 10%, remember that 10% from when I started, 10 to 15% of people who die from pneumonia die despite immediate starting of penicillin when they come to see us because it's too late. And we know this now in terms of things like the sepsis cascade, and eradicating the organism, that part is no longer going to make a difference. And he said, if you want to save these people, you've got to prevent the illness. You can't wait for them to come in and give them penicillin. They refunded his research. He did the definitive trials of the early pneumococcal vaccine, which were in South African gold miners who have extraordinary rates of pneumonia. And the vaccine was licensed. Now, it turns out the vaccine is not so great, and that's why we have a new vaccine that I'll talk about in a sec. But it's incredibly safe, and it probably does save lives. And so we've been giving it forever, frankly. But when the resistance was emerging, many people pulled out this figure because they said, well, if we didn't have penicillin, is this what we're going to go back to? And so it was a very scary time. And so a lot of interest in what we should do about resistance. And that's why people started grabbing for an antibiotic for which there was no resistance, because they were unwilling to see people die in front of them from pneumonia. We're not used to that in this country. So the question is, well, when would you use a second-line agent, and when would you be okay giving somebody penicillin? And it turns out that the single most powerful predictor is their prior exposure to antibiotics and where they live. So this is a study that showed that your risk of getting a drug-resistant pneumonia goes up exponentially depending on if you've received an antibiotic within the last 60 to 90 days. Actually, the sort of ground zero for a troubling agent is azithromycin. This is a separately very fascinating story. So we like azithromycin as an agent for pneumonia. Why? Because you only have to give it for 3 to 5 days. And why do you only have to give it for 3 to 5 days? Because it concentrates in the lungs, in the neutrophils, and it stays around forever. And that's like the perfect storm if you want to select for resistant organisms. We know if you expose people to low doses long term of antibiotics, they're going to get colonized with resistant organisms. It's just perfectly selecting for these resistant organisms. So you can actually, maybe I'll show this to you. Let me see. You can plot, this is beta-lactams, but the curve is amazing. You can plot a country's use of azithromycin against the probability that their patients in that country get drug-resistant pneumonia, and it's a perfect line. So if you're going to go traveling and you're concerned you're going to get pneumonia, I would much rather go to the Netherlands than to Spain. Now, why Spain uses so much more azithromycin than the Netherlands is a separate conversation. But the fascinating thing is it's not just the individual's exposure, but your community's exposure. And so that's why this has turned into a kind of a public health conversation. It's not just whether I took an antibiotic or not that relates to my risk. It's whether all of us took antibiotics or not. And this is why there's so much, especially all of a sudden, again, the new executive stuff from Obama office around our need collectively to figure out how to rationalize this problem. So the problem, however, and so I'm going to apologize now because I'm going to show you some of the research that we've done over the years looking at the risk of drug-resistant pneumonia and how to think about what an individual's risk is. And I freely admit that there are places called New Jersey and Delaware that are not pictured on this map. And I don't want this in any way to like make you angry, but we have done studies for many years that were funded by NIH that only looked at the risk of this disease and the epidemiological features of it within the 5 counties around Philadelphia, assuming for all intents and purposes that nobody in their right mind would cross the border if they got sick. And I acknowledge that's a problematic, particularly to this audience. Maybe New Jersey. Let's go. New Jersey. Nobody's going across the river, but Delaware, yes, people can come down 95. So fascinatingly, and this is sort of an interesting reverse discrimination thing, the further you are from the center of Center City, the higher your risk goes from 8% to 20% of having a drug-resistant pneumonia. Why is that? It's because it's a reverse disparity. The more affluent the community you live in, the more likely the children and adults in those communities are to get antibiotics. And the more likely they are to get antibiotics, the more likely the community is colonized with drug-resistant bacteria. There's a kind of an irony here to all of this that has actually tracked with some of the experience in Europe as well. So this is this network that we created, which was variably about 48 hospitals in the 5-county Pennsylvania region that for many years has been sending us all of the pneumococcal the isolates from the patients and the epidemiological data about who's getting pneumonia in this region. We can look at the organism, we can look at the host, and we can do a lot of epidemiological research, which has been very helpful. These are where these hospitals, again, I know you guys are down here. I really should have doctored this map, I'm thinking. So here's a fascinating thing. Each of these H's is a hospital, and the size of the H is the percentage of isolates that that hospital has seen, or the percentage of patients that that hospital has seen that have a drug-resistant pneumonia. And so the interesting thing is that in just pure geographic location, there's no relationship here. Remember, I showed you the other map. There is a relationship, but there's no relationship here based on where the hospital is located. And that's because different hospitals have very, very different catchment areas, which is an important issue. But this is a problem because the only way that doctors get to know which antibiotics to use or not typically is that the hospital that they admit to gives them something that looks like an antibiogram that says, the last 1,000 people we saw, this is what it looked like. And if that doesn't actually relate to what's going on in their community, if they're an outpatient doctor, it's a very misleading piece of information. And we don't have a system, regionally, statewide, nationally, to give doctors good local information. And so going back to that recommendation in the guideline, you should look at your local data and decide what to do. Turns out it's very problematic because there's no really good source of local data. There's this sort of distorted source of what your hospital does, which is very different. All right, so then the last piece, and then I think I'll have left a bunch of time for conversation. So we talked about diagnostics and sort of the challenge of how to introduce decision support into a setting in which people's willingness to be wrong is at a very high point. And so how good does that decision support have to be? We talked about treatment in which the right treatment decision is influenced by some public health considerations, but that data is rarely available, and it's very hard for doctors to know how to manage that. How you do what people call antimicrobial stewardship in the outpatient setting is really one of the great challenges here. But I saved the best part of the story for last, which is this prevention story. So, so let's go back to this research that we've been doing for a long time. These are, again, these 5 counties. And each square here is the home location of somebody who got pneumonia in 1 year of this study. I actually jiggered the squares a little bit to protect people's identity. They actually asked me to do that. I'm just like, are you kidding me? So, so you don't know who that is, even if you think you do. Don't even think you know who that is. Now, maps are a really interesting tool, and thinking about patterns in healthcare. So, does anybody know what this map is? What? Yeah, this is John Snow's famous map of the cholera outbreak in Soho, outside of London, in the 1850s. This is the Broad Street pump. This is the famous pump that all the cases aggregated around, and he made this map of all these cases of cholera. And I guess the story apocryphal is like, right, and then they took the handle off the pump. And supposedly then the cholera cases went away. Now, the truth is the cholera cases were declining long before he took the handle off the pump, which he admitted. But most people say, like, he cured cholera in London because he made this map, and then he went right to the pump and took the handle off. But still, maps are really fascinating, I think, and tell us a lot about not just the epidemiology, but of the patterns of disease, and can sometimes give all kinds of interesting solutions. So let's look again at that map where I showed you where people were living. And now I'm showing you the sort of the population density of pneumonia. Right? And what I'm showing you is that the risk of pneumonia by county, or not by county, I'm sorry, these are by metropolitan areas or sort of aggregates of zip codes, can range from up to maybe 3 to 4, 5-fold higher in some neighborhoods compared to others. There's actually rather impressive variation, not just in the number of cases, which you would expect, right? If a denser neighborhood is going to have more cases, you have more people, but actually in the rate of disease in different communities, controlling for the density of the community. And so in mapping world, if you do research in maps, a lot of what people do is look for hotspots. There's dozens and dozens of statistical ways to do this, to ask, is the observed counts in this area higher than expected relative to other areas, or lower? Are there sinks or are there peaks? And these red neighborhoods are peaks. They're hotspots of pneumonia in Philadelphia. This is just Philadelphia County. And so for those who know where these are, this is West Philadelphia and north here of Philly. These are largely black communities in Philadelphia. Now, so you're going to remember that I said that it's been known for many years that the incidence of pneumonia, particularly pneumococcal pneumonia, is several-fold higher in African Americans than in whites. And actually, when the vaccine for kids was first introduced, and we're going to talk about a vaccine in about 2 minutes, it was recommended to over-vaccinate or extend vaccination to much higher ages in African Americans than in whites, because epidemiologically, it's true, they're at higher risk, even though nobody understands why. And that was a policy disaster, right? Think about it. Here's a new vaccine with relatively limited safety data, other than what was done in the pre-marketing. That was suddenly a policy that we should sort of over-vaccinate one vulnerable group while the other group just sort of got a lower level of vaccination. It was an amazingly big policy blunder, untenable. But at some level, if we're doing it just from like a cost effectiveness analysis, if you didn't think about things like that, it made sense. It made sense, but it doesn't make any sense as a policy. But it particularly doesn't make sense because nobody understands why this is happening. If we understood why this was happening, then maybe the policy would be more sensible. So the question is, well, why is it happening? So in infectious disease, we talk about the triangle of infection. There are 3 components to any infection. There's the pathogen, the bacteria or virus. There's the host, the person who gets sick, and there's the vector. There's the thing that bring those things together, right? So if you ask the question, why are there some communities where pneumonia is occurring much higher than it should be relative to others, you could hypothesize, and these are not mutually exclusive, that some communities have more virulent bacteria in those communities for whatever reason, random assortment. Just they got the bad bugs there and not elsewhere. You could say that there's something here related to the host. There are more vulnerable populations in some communities, less immunity, or lung function, whatever. Or you might say that something about how the disease is transmitted is different in some communities than in others. Right? Fundamentally, if you observe a hotspot in infectious diseases, this is where you have to hang your hat on some or all of these kinds of ideas. And I think understanding this is crucial to understanding then what the policy should be around it. Just observing it doesn't really get you to what you should do about it. Okay, so this is the famous, infectious disease triangle, in which we think here transmission, the pathogenicity part, and the host's ability to resist infection. So let's just dive into each of these parts of the triangle, and I'll show you evidence that we've generated and how we did it about whether these are the explanations. So the cool thing in infectious diseases is that you can actually fingerprint every bacterium now. Was done crudely at the time with just pulse field gel electrophoresis, so chopping up the bacterial DNA into big blobs and sort of looking at the patterns to try to create clonal groups. Nowadays, we might even do whole genome sequencing to really find resolution here. And so then you can create a phylogeny, right? You can ask if any two bacteria are more closely related to each other than any two others, right? So all else being equal, if I got an infection and I gave it to you, we should have bacteria that match, right? If you and I both get pneumonia at the same time, but we got them from two totally different places, then our bacteria may not match. So looking at the phylogeny of a particular pathogen can tell you a lot about the relationship between people and where they got their infections. It's completely changed how we do infectious disease research now. In the old days, we would just make all kinds of inference that Tom gave it to Sue or Mom gave it to Dad, but now we can actually challenge that question with real data in this kind of manner, okay? And so I've gone back to that map. I've jiggled it a little bit and simplified it. It's a much shorter period of time. And I've shown you all the cases of pneumonia and color-coded the clonal groups. So for example, the blue ones are much more closely related. They come from a common ancestor. The purple ones, the red ones, etc. So if the hypothesis that this was about the bacteria was right, then you'd expect these colors to cluster, right? There should be worse bacteria here than, right? So there's no pattern, right? You don't need me to do, there's statistical tests here. I'm just showing you the raw data. There's no pattern to where these bacteria are that would suggest that the bacteria that are causing disease in one community, let alone one country, are any different than the ones that are causing it anywhere else. And in fact, this is a fascinating thing, that these bacteria are so highly transmissible and are so ubiquitous, these respiratory pathogens, that I often say, the Kevin Bacon game, how many degrees are you separated? I think globally, we're all 6 degrees separated by sputum. So everybody in the world is only 6 people separated by what's in your mouth. It's gross, but it's probably close to true. The kind of amazing network power here is that bacteria are just constantly moving globally like this. And so we can kind of ignore what's going on in Southeast Asia with, highly drug-resistant respiratory bacteria, but they will be here extraordinarily quickly. And on small-scale levels, it's all distributed. There's no pockets that are bacterial-driven. Okay, so we'll dismiss that hypothesis. Let's talk about the vector. So this is the punchline of the story I got to you before. How is pneumonia transmitted? Right? So what are the vectors, if you will, the insects of pneumonia? Children. Children are the vectors of pneumonia. The pathogens that cause pneumonia, the respiratory pathogens, in particular pneumococcus, pretty much only live asymptomatically in the mouths of children. Adults do carry it, but very transiently. It's children who are colonized with this bacteria. And so children, and then on top of everything else, the age group that sees the most antibiotics per year are children, mostly from otitis. So and where do children hang out? Usually between the ages of like 3 to 7. They go to nursery schools or daycares and they swap spit. Somebody just had an antibiotic, lots of teeming bacteria running around. They go home, give grandma a kiss, and she dies. And this is the story of pneumonia. And so you could imagine that there are draconian solutions to this problem. We could imagine bed nets for children or something like that. And so here's a very fascinating study that looks at communities and says the probability that kids are carrying the bacteria is a function of the fraction of kids in daycare and the size of the daycare in that community, the average size of the daycare. Bigger daycares, more kids in those daycares, those communities, more kids are running around carrying bacteria. So now we're getting some little insight into what's different in one community versus another. A lot of it has to do with this vector issue. Now, the amazing thing is, and I hinted at this, is we had a vaccine for adults for pneumonia, but it didn't work in kids. It's non-immunogenic. It's just this polysaccharide coat of the bacteria, which in little kids didn't generate much of an immune response. And this is a problem because there are 2 big age peaks of pneumonia, newborns to 2 years, and then older adults. And so kids are dying from pneumonia up until recently because we had no way to prevent the illness in them. And so somebody very cleverly, and that was the problem with the polysaccharide vaccine that Bob Baustrian created, is it didn't work in infants and children. And so hence the creation of something called the pneumococcal conjugate vaccine, which you know is Prevnar, where they took these polysaccharides that were in the polysaccharide vaccine and stuck them to a protein. In this case, I think it's diphtheria toxoid or tetanus toxoid. And so now in infants that need T help to generate an immune response, infants respond robustly to this vaccine. They generate huge immunity, all right, and it protects them from having pneumonia or sepsis or meningitis. It's dramatic. I'll show you in a second. The amazing thing is it also reduced their risk of carrying the bacteria. So not just in prevent disease, but prevent them from even being carriers. Now, the tricky part we'll come back to in a second is the first vaccine only had 7 serotypes. These bacteria come in many different immunological variants. There are actually 90 of them that have been characterized. We picked the top 7 when I didn't, when they created the first vaccine because they couldn't. I'm trying to imagine little people putting these polysaccharides on proteins. I'm sure that's not how it's done, but they couldn't put more than 7 on the original protein carrier. Globally, actually, this was a bad vaccine, which is a separate policy issue, which is it's a poor match in many countries, but nobody wanted to make a country-specific vaccine. This was made for the United States. And so it was released. And amazingly, the next year in the New England Journal, invasive pneumonia in kids almost vanished. This is one of the triumphs of the last 20 or 30 years in medicine. If you are an NIH-funded pneumococcal researcher like me, this is like the saddest day in your life, you know. You pick up this thing and you go, okay, well, what's the exit strategy? I don't have a plan B here. This is killing me. It's going to come out okay for me in the end. Don't worry. The bacteria are coming back. But the fascinating thing is that disease didn't just go down in kids. It went down in adults, even though the adults never saw the vaccine back then. Nobody vaccinated the adults. But grandparent ages, if you will, and parent ages actually saw significant declines in the risk of pneumonia, presumably because we were immunizing the vector. Right? And not just that, let's have it. So this is what we call herd immunity, right? You target one group to get benefit for another. And there are really fascinating policy implications of this, right? Because the kids are getting some of the benefit, but also the risk, but the adults are getting all the benefit. This is true for flu vaccine, too. There's a famous study in Japan which showed that if you wanted to save older adults from dying from flu, you should vaccinate all the infants. Now we vaccinate everybody. It's a little bit different. But at a time we didn't know who to vaccinate, it was a mistake to vaccinate the weakest people in the population. You should vaccinate the carriers, because then they won't actually transmit the disease. The fascinating thing here is that not only did disease go down, so it went down a lot in almost every age group. I mean, it's just a dramatic effect. And this is a study we did which showed that, you know, even if you did a case control study in households in our region, if your kids in your house were vaccinated, your odds or probability of getting pneumonia were much lower than if you hadn't vaccinated your kids. Now vaccination is almost ubiquitous, but back then there were vaccine shortages and et cetera. And actually, there's almost a dose response here. So the more kids you vaccinate in your home, the lower your risk is. So just the opposite of how it used to be. In the old days, the more kids in your home, the higher your risk of pneumonia. And now it's actually that the more kids you have in your home vaccinated, the lower your risk. But the other punchline here was actually resistance went down because the kids weren't just transmitting bacteria, they were transmitting resistant bacteria. And so suddenly now we had a strategy to deal with not just reducing disease in a population, but reducing drug-resistant disease in a population, which nobody had thought was possible. So vaccination is actually a strategy for dealing with antibiotic resistance. Because if you reduce the carriage of the resistant bacteria, even if they're taking lots of antibiotics, they're not going to transmit it. And for the first time in many years, actually the probability that adults or kids would get drug-resistant pneumonia went down sharply. And this was a huge success for the vaccine. But it's not over yet. There's not so much shortages anymore. But what's happened is what we'll call serotype replacement. So those serotypes that we've eliminated with this vaccine, they're gone. That's great. But the bacteria evolve, you know, and they actually are filling an ecological niche that was previously inhabited by other bacteria that we've taken care of with the vaccine. It's actually more complicated than that. There's a really powerful hypothesis that's been recently shown that these bacteria that cause pneumonia live in the noses mostly of kids, and they're competing for nose space, I guess, with Staph aureus. And the other thing that happened when we vaccinated kids was Staph aureus colonization went up. And you can actually show that the risk of methicillin-resistant Staph aureus is related to the introduction of this vaccine. So you win, you lose in this kind of public health thing. And it's sort of interesting as you think about how to study this is how we're going to trade off those different kinds of issues. This just shows you that the types of pneumonia that were included in the vaccine have almost vanished. But the types of pneumonia that are not included in the vaccine have started to rise steeply, and this is our own data from this region. So now we have PCV13. So they took the 7 that were in the original infant vaccine, right, and they added 6 more, which were the newest 6 that kind of come online. So now if you have kids, they get PCV13. But remember, I told you there are 90 out there, so like it's not clear that this strategy is going to keep going. And then last year, just a year ago, American College Immunization Practices recommend that we give it to older adults too. So I don't know how many are in clinic and primary care, but if you have an adult who's 60, 65, they're supposed to get Prevnar now for the first time. And it's actually a little controversial because the trial was done in Europe in an area that had yet to introduce pediatric vaccine. So we are heavily vaccinating adults with this vaccine, but we've already vaccinated all the kids. It's not so clear that there's a lot of benefit for the adults, but it's now a recommended part of the vaccine series. And so here in this research space, it's sort of interesting. The epidemiological data has really been very informative of thinking about this, but it's also led to some policy recommendations that don't quite fit with the real world. And so I think there's a great research agenda still ahead. So I'm going to end and just say we have these new vaccine trials. We don't yet know what the consequences are going to be of all this mass vaccination. It could dramatically change the epidemiology of this disease. We could see new kinds of serotypes that cause different disease. We don't know. But it has, to be clear, had enormous benefit in the public health level. I think testing is going to change a lot. I do think bedside procalcitonin testing is coming. We did a trial with a bedside CRP testing, which was the precursor to this. It wasn't so good, but I think procalcitonin will be better. Although still, I don't think anybody's entirely sure how you should use this in practice. I think we have a lot of questions still about which are the right antibiotics to use. We don't really typically pay for the right kinds of pragmatic trials that answer those questions. New drugs come on market through new drug trials, which don't answer the questions we need to understand in this setting. And it's left us very hard. I can speak as, in this guideline committee, not great evidence about what to tell people to do here. To get a new antibiotic approved in this country, it just has to be as good as what's already out there. And so some of you will know that it's a lot easier to run a no difference trial, because it kind of lets you get away with a lot of sloppiness, than a trial that's actually going to show something superior. But you don't have to do that if you're making a new antibiotic. You just have to be as good as good old penicillin. And in fact, for that reason and others, and partly because it doesn't even compete with the money markets of lifelong statin drugs, nobody's making new antibiotics really anymore anyway. And so this is a problem that isn't going to go away in terms of how to steward these drugs and use them smartly. So many people involved here, including Bob, who unfortunately passed, but many other people. And so I'll end there. I went a little bit long. I apologize, but I think I left about 5 or 7 minutes or so for some questions. So thank you for your attention. I'm happy to take some questions. Yes, please.
I enjoyed your talk. When you were talking about the prevalence in the African American community, I thought you were going to talk about sickle cell, because about 1 in 12, they autosplenectomized, they have encapsulated organisms. So I was just wondering, are there any difference in treatment guidelines for sicklers regarding the vaccines and so forth?
Well, as you know, early on, polysaccharide vaccine was recommended even in patients with sickle cell, other people who've been splenectomized, and so on. Still not a very protective vaccine. The Prevnar vaccine has been much more powerful. Now we have universal vaccine for all newborns, and so there's effectively no subgroup that needs additional Prevnar vaccination, particularly among kids. I think this issue is a fascinating issue about host susceptibility. That was the part of the triangle I didn't talk about, right? So the third part of the triangle is, are some people getting more pneumonia because immunologically or for whatever reason they're just much more susceptible, and that could be related to nutrition, it could be related to other chronic diseases, it could be related to host things. I think that's undoubtedly true, and that is probably part of that map I was showing you. I don't think it's all vector stuff about how much density of kids together and all, although I think the kids part is the policy interesting part, but I think the host part still remains a really important issue. And whether we should come up with even better vaccination strategies for these high-risk groups, I think, is an open-ended question.
Great presentation, really. I think some of the challenges, just to give you context, we recently got procalcitonin back here as an in-house test.
Yep.
So turnaround time for inpatients, hour plus, maybe 2 hours, but something that can help with diagnostics. But it's interesting because it's the same challenge of not knowing how to interpret these values and helping, and like we use it for more upstairs in the ICU, they use it for de-escalation therapy, but guidance for initiation is something where there's a challenge, I think, up front. I think one of the things that, it's not really the topic you asked, but I'm just kind of curious on your impression with, we have rapid and improved rapid diagnostics for viral, so RSV and influenza for inpatients, and there's even still hesitation about not giving antibiotic coverage for those patients, even when you have a known viral entity, just because it's like, well, I'm going to double cover and make sure everything's okay. And it's, that has been what we've noticed and seen more prevalence of the predominant viral as a cause, even for a bad, has that recommendations been included when they've discussed like viral entities and coverage, the lack of coverage that's needed. I mean, that's a challenge that we see with just recommendations internally and compliance with antibiotic stewardship and stuff. So.
Yeah, no, I think these are both great points. I mean, on the first point, and the other issue I really didn't talk about at all is that, therapy for pneumonia isn't just about anti-infectives. So the other issue here is that, one of the reasons that there's a lot of data that's been around for a while that macrolides are important in the treatment of pneumonia, even if you have another antibiotic on board that covers probably for what the pathogen is. And there's been hand-waving, but there's some belief that relates to immunomodulatory components of macrolides. And you may have seen, I think it was in Test or one of the other journals recently, maybe it was actually Annals, it was a large meta-analysis of all the studies of steroids in patients with pneumonia, which suggests probably the margin there's benefit, at least certainly for the ICU patients. Although it's been hard to show that consistently, it's probably enough out there, right? So this emerging idea that we sort of have too much or too little immune response and trying to get people right in the middle. On the issue of co-pathogens and viral diagnostics, this is a huge ongoing issue. We've not had any good trials that I'm aware of, and we're looking at this actually as part of the guidelines, where people have done sort of trials of de-escalation therapy to show that they're just as effective or safe. We do all these tests, we still recommend them, but actually the data would suggest that nobody pays attention to them. There's some amazing studies of the degree to which we all know that supposedly blood cultures at the time of arrival in the ED for someone with pneumonia is a quality measure. So it was getting antibiotics within 20 minutes apparently. But there are also parallel studies that show that nobody changes their therapy based on the results of blood culture. So what's the mechanism there? It doesn't make any sense to me. Like the only way that diagnostic tests, microbiological diagnostic tests can help is that they focus therapy. Otherwise, they're a marker for something else that I don't quite understand. And so this is still an ongoing issue. And I would love to see some trials of different test-treat strategies, not just test strategies or treat strategies, but really link test-treat strategies to get at exactly this issue. Yes?
At a clinical level, there are a lot of handoffs that happen. I work as a hospitalist here. Has there been any research looking at antibiotic stewardship when more handoffs are happening? I mean, when you make the decision as the admitting provider to not start antibiotics, it's a brave decision. But you kind of face the scrutiny of the people that you're handing off to. And so in certain cases, you might just put them on because there's no one that's really going to be watching them overnight.
Yep.
The person that picks them up in the morning.
Yep.
And so has anyone looked at handoffs?
So I'm not aware of, it's a really great question. I'm not aware of studies that have specifically tried to correlate like the number of handoffs with the number of antibiotics, although I do think that's an interesting question. I wouldn't be surprised. I think the word cavalier haunts all internists the next morning. It was rather cavalier of you. My position in general is, as regards antimicrobial stewardship, is that it's not about the decision in the first 24 hours. I honestly could care less what people do for the first 24 hours. It's what happens subsequently. So I think if you're in doubt, we do know that early initiation of antimicrobial therapy does make a difference. Pneumonia may be a little controversial. No question sepsis. I mean, there's definitely obvious situations which, if it's on your differential, I would treat it early. But I would have a plan, it gets back to this sort of test treat, to be able to reevaluate in 24 or 48 hours how likely is that, in fact, was that part of your differential. I think getting behind 24, 48 hours, that's the 10% of people who died. I mean, that is a problem, and I understand why people look at that. And there's so much evidence in favor of treating quickly that it's hard to resist too much at the point of starting care. What we need much more, and that could relate to the handoffs, is, well, what were you thinking and what are we thinking now? And that's where I think some great interventions could be tested. Yes.
So do you think there will be, with this vaccination, do you think there will be a day where the pneumonia will not be resistant anymore to penicillin, for example? That we could reverse all the resistance, the antibiotic resistance?
So it's a couple of parts. That's a whole long. So let me a couple of things. one of the things which is frustrating in those of us who think about antimicrobial stewardship is that we don't really know how low you have to reduce overall use to actually make an impact here. Even if we got everything down to just the appropriate amount of use, and got rid of all the inappropriate, that it may have very little impact on what we really care about here, which is trying to slow resistance, let alone make it go away. So I think that's an issue. A second here issue is actually we have almost no penicillin resistance anymore to these bacteria, not because anything good happened microbiologically, but it turned out for years what's it called now? CLSI, the Committee for Laboratory Standards Institute, a steer body that actually decides what's resistance and what's not, knew that the current levels of resistance that we were reporting out for penicillin for pneumococci were below the levels of penicillin you achieved, or amoxicillin if you gave standard or high doses. And yet they still reported the organisms as resistant. And this was because it depends where the infection is. If you have meningitis, the levels are inadequate. But if you have a respiratory infection or bloodstream infection, the levels are not. And for many years, I was part of a committee that kept writing them and said, you should reset the standards because you're letting people think there's much more resistance than there is. And they refused to do it because they didn't think doctors could handle the complexity of that information. Today, if you get an isolate back, it actually gives you two different interpretations depending on whether the isolate was from the CSF or not. If you've got a pneumococcus back, it'll say, if this is in the CSF, you better not give penicillin. If it's in the lung, go right ahead. Knock yourself out. So actually the problem for respiratory infections turns out to be much less than people said, which is one of the problems in all of this was you would have thought with all of the resistance on the map that I was showing you that people should be dropping dead of pneumonia all over the place, and it wasn't happening. There was a true disconnect between what people were talking about in the lab and what was actually happening epidemiologically, and this was the reason. We hadn't crosswalked them very well. Resistance is a real problem, and there really are failures. I don't want to, but it was overstated dramatically because of this problem. Okay, I think that's the wishing hour. Thank you again very much for inviting me.